Good afternoon. Please take your seats and we will start the next panel. Before we do that, some logistics information. For those of you who have any questions about transport to the airport, either today, tomorrow, or the following days, please approach the team at the conference desk in the hall at the back. We are now going to have a double panel session, panel 1 and 2, in the next 2.5 hours, 2 hours and a half. Then we will move to the final reflection panel and then have a small break before we have the closing segment. The panel we will open now is entitled International Partnerships, the Global Perspective. So far, since yesterday morning, we have been through different scenarios in the type 1 diabetes space, from country level to global level, to clinicians' perspectives, people with lived experience, and now we will focus on the international partnerships. The first panel is co-moderated by Sylvia Kehlenbrink from the International Alliance for Diabetes Action and by Sylvia Bahendeka from the East African Diabetes Study Group. And I'll invite you to take over from here and invite the panelists. Thank you very much.
Good afternoon, everyone. I hope you all had a nice lunch and are ready for another panel discussion. So the topic today, as Bent just mentioned, on international partnerships, a global perspective. Again, just by way of introduction, I'm Sylvia Kehlenbrink. I'm an endocrinologist, adult endocrinology, based in Boston at Brigham and Women's Hospital, and I'm the director of the International Alliance for Diabetes Action. So, international alliances are critical to this work. I think that has come out strongly over the past few days. But international partnerships, they have very high value, very high importance, but they're also challenging to pull off well. And so today we're going to have a conversation. So 2 panels, ours first, with 3 programs that are very well known, I think, to everyone here, I will say, with 3 panelists. And I guess as I give your names, if you can come up and sit at the table. But first we have Anne-Sophie West-Olsen. She's the project director in Global Health Equity at Novo Nordisk and leads the Changing Diabetes in Children Partnership. She has a PhD in political science and extensive experience in access to social services in low and middle income countries. Then we have Graham Ogle. He is a pediatric endocrinologist and the general manager for Life for a Child at Diabetes Australia, and he's an adjunct professor at the University of Sydney. And then third, we have Anna Makumbi, an associate professor of cardiology and a lead researcher at the National Public Institute, Health Institute Mozambique, and co-leads the NCDI Poverty Network, advancing the PEN Plus program. And so we're going to learn about these partnerships, what they each do, and how can we better coordinate and align on our joint initiatives in improving diabetes care in these settings, and some ways of achieving the global diabetes targets together. The structure will be 5 to 7 minute presentation by each speaker, followed by some discussions. And I'll now call up my co-chair, Sylvia Bahendeka, for a few words of introduction as well. Thanks.
Thank you very much, Sylvia. This, to us, is a very important session, particularly that we have been looking at this group sometimes like Oliver Twist, but this time it's not going to be Oliver Twist, give me more. It's actually going to discuss how collaboration and with low research settings can actually get things done without the people down asking, give me more. If we look at global reach, local impact, we are looking at globally, these are the groups we are looking at. How will they collaborate together to make an impact? Access to life-saving resources, how do we get to them in different capacities to make sure that in one country they can still make an impact to the very one patient with diabetes. Capacity building. Again, we are asking 3 different groups operating probably from 3 different countries to come and build capacity at one source, and the capacity should be cohesive and the wheels running forward and not getting stuck. This is why we have this panel discussion. Holistic care, again, these are the things that we look at when we want to run programs, the programs they run. They may not be aware that I'm actually asking from Life for a Child. At the same time, Pen Plus is also going on, and we want to build capacity in the face of the country, in the face of the child, and that the outcomes are going to be satisfactory to the child, to the government, the community, and to them as well. And then there is the data sharing and research. It's necessary. If we want to move forward the work they do, we need to share data, we need to do research, we need to publish the work, they need to know what's happening, the impact has to be seen. So, and then lastly, empowering individuals and communities. This is one of the things that is important if they are going to say, at some stage we are going to leave. They are not going to be there forever. At some stage they are going to say, I think we came to have you grow, get strength, it's time we go, but we don't want to throw the baby in the bathwater, as it were. We want to leave you thriving. So that is the reason why we have this panel discussion, and they will be discussing these in different ways, but at the bottom line, this is what we are looking for. Can I now ask Sophie to say a few words, or even at length, exactly what she is doing? Thank you.
Thank you, Dr. Bahendeka. Is it working? Good. Well, thank you. I will try to say a few words about the Changing Diabetes in Children partnership, but for many of you, you will already know. So I'll try to be brief and talk about both the past, but also the future, what's happening. I think to start with the past, reach, there was a target set in 2020 to reach 100,000 children, obviously, which complements the target of Life for a Child of 150,000 children, which we basically led by the countries and the partners are moving steadily towards by 2030. We are currently in 30 countries, collaborating and supporting local partners, diabetes associations mainly, but other also different NGOs in different settings, or individual clinics across approximately 600 clinics, supporting currently 65,000 children that we reached on a monthly basis. We have 4 global partners in total in the program. Main sort of first partner is also Roche Diagnostics, that together with us provide and support and donate to the children what they need in glucometers and strips. This support is mainly done within 4 components. I would have to say that a lot of this work is really, all of the work, frankly, is led by the country partners. So within this framework, we adapt and listen to the country partners of what really is being driven by the local partners that year, the next year. We do long-term contracts so that it isn't a year off. We know it's a chronic disease. We know that there needs to be, it takes time also to do different elements. So we kind of align with the country partners over a longer term period to say what are the key elements within first component, children first, everything that has to do with patients, patient empowerment, and whatever needs to be done in terms of camps, the traditional sort of patient education targets, even if it's home visits, the different elements. It's actually, again, very flexible and depends on what each country is driving within their strategic approach to improve care. The second component is everything that has to do with HCPs, doctors, nurses, what is the current status in the country and what is the level of need, both in terms of initial diagnosis. For example, it could be in hospitals, what type of diagnosis training is needed, initial training, or more advanced training. Again, this is very flexible and defined by the partners in terms of this is what we're planning this year, this is what we're doing next year, this is what we see in terms of needs, capabilities. So there's a big difference what is needed, obviously, in Uganda versus, for example, in India in some cases in this setting. Third component that we structure the support around is everything in clinic. How do we really improve and how do we actually bring care closer? So it's not only the physical support. That support, we kind of try to also be a little bit cost efficient. I think we try to do that across all components, but in this component, we kind of try to say, okay, there's some of the physical hard elements, what is needed in terms of infrastructure and all that, should be upfront. The longer term investment, because we know it's a chronic disease, so a lot of you are already negotiating with your governments and everything is in public hospitals, that majority of the work is being done. So we only kind of add to what's already being done as part of a public system support. But we do also now, we have been moving towards increasingly the more soft element. What is the digital solutions that are needed in the clinic? What type of, how can we, not that we have access to any of the data, but how do we actually support those procedures? And I think a lot of that is trying to sort of put together, for example, there is a open source, no license registry system developed that people can either use or copy. That's already been developed thanks to a lot of the input of all the different partners. So that one is available for not only the countries in NCDIC, and I think that's also the logic. It really is to build on the knowledge that the fantastic leaders are really empowering throughout the different components and countries. And then there's a fourth component, which is the insulin supply and medical supplies that we do still donate in countries that need insulin. We are trying to make sure that none of the children in these difficult times today are downgraded, and we are actually moving towards an upgrade of better insulins. But we're also really not, I would say, really try to coordinate, collaborate, but especially really support national structures to ensure that every single child and also adult has access to insulin through the national system. So I think those are the main 4 components. That is sort of what we've been doing so far. Now, what is coming in the future? There is a lot of pressure towards sustainability, empowerment, collaboration. I've been hearing a lot of very interesting discussions the last couple of days about how is this integrated into an NCD agenda. We will also hear that later. So I think a lot of those discussions also happening internally. What is actually the future is of the type 1 and the NCD space. We only have a target set until 2030. So there is not as such currently a commitment beyond. And I think a lot of that is being defined currently by everyone here. What is really going to happen in terms of sustainability? What we try to do is, again, be very cost efficient. I think one of the things that we have tried to definitely improve is we know that there is overlap in some of the countries with Life for a Child. Historically, that is how it's been set up. And in the future, in any new, we are not as such going into new countries. And what we've tried to do for the past couple of years in the collaboration space is to not do that, to simply be more cost efficient with the few resources that are available in type 1 to make sure that everything is developed, can be applied to other countries. I think what we're also trying is really to make sure that whatever is being developed across the countries today, that any country can have access to it. Even though we don't go in with the old sort of model, the heavy model, we do try to give this freely to everyone, everything open source, available, so that any country can sort of join and get access. We try to digitalize everything and invest more so that whatever is done in Malaysia can benefit other neighboring countries. So that's kind of the principle that we're following the next couple of years. Yeah.
Excellent. If I may summarize in one sentence, she says she will give the country, and it's the leadership in the country that will have to implement and make sure that what they give is going to be useful to their community, and she will not use the whip. I wish she would have the whip as well. So thanks very much. We shall be getting back to you. Let's get to Graham, and Graham will tell us what she does, and then later we shall put all of them together and see how the receiving country now is going to benefit. Thank you very much.
Thank you, Sylvia. Hello, everyone. So very briefly, Life for a Child, it started in 2000 as a program of the International Diabetes Federation, managed from Australia. And then in 2018, it became fully under the auspices of Diabetes Australia in Sydney, but the IDF is still involved as a partner. And the vision of the program is that no child should die of diabetes. And we work with local partners in a similar way that CDIC does. We look for local champions, centres, that they might be national diabetes centres, national diabetes associations, children's hospitals, and that are actually already caring for these young people. And then we support them as according to their needs and according to what we can do. And we help with insulin. We can now give insulin in pens and cartridges with analog insulin as well, in long-acting, meters and strips, HbA1c, education materials and other support. We're now supporting over 60,000 young people in 53 countries with a goal to go to 150,000 if we can by 2030. And we help young people up to the age of 25, or in low-income countries, and also Haiti, we help up to the age of 30. And the key partners are the Helmsley Trust, Breakthrough T1D, and Eli Lilly. Eli Lilly provide insulin and also help with funds for the program, but they don't have any role in governance or strategic direction at all. And I know we've been called a donation program a few times over the last few days. I used to bristle a little bit when we're just called a donation program, because I think, like CDIC, we're a lot more than a donation program. We are a donation program, but we do a lot of research. We've published over 75 papers now. The T1D Index, which we do with Breakthrough T1D, the IDF Atlas, and we're releasing new numbers, global numbers in April in Bangkok, all sorts of other research projects. We do a lot in training as well of health professionals, in education materials, and also advocacy. And two examples of a partnership. The first is a partnership we have with ISPAD, the International Society for Pediatric Adolescent Diabetes, so the doctors and nurses involved in diabetes. And we developed guidelines with them. We simplified the ISPAD guidelines for less resource settings, because if a doctor has a child dying in front of them with ketoacidosis, they don't want to know all the ins and outs. They want to have a cookbook of what to do first and second and third. We do workshops with ISPAD. We've developed carb counting materials with them. I've done a task shifting study with them. ISPAD support attendees from centres that we support to come to their annual meetings. ISPAD are also involved with the T1D index. And recently we've established a mentoring program where there's a mentee who decides what she or he would like to learn, and then we arrange a mentor from them, and over a 6-month period they can achieve those goals. And an example of a country where we support, there's many that I could choose, but I'll choose Mali in West Africa, and our partner there is Santa Diabet, and who in turn work very closely with the Ministry of Health, and Stefan Besançon is in the room. The numbers, we started with 14 young people, another 14 were found over the next few months, making 28, and the number is now over 1,500 young people there, and it's growing all the time. We've done research with Santa Diabet, looking at the phenotypes of diabetes there with HLA and C-peptide and autoantibodies, on incidence, prevalence and mortality, on cost effectiveness of care, and most recently on a randomised controlled trial on the benefits of long-acting analogue insulin. And then Santa Diabet in turn are very much involved with the Francophone medical community, and there's groups like PDAF and other groups who are supporting training there. And finally, the model in Mali has been so successful that they've exported that model to Burkina Faso, which has had a very similar trajectory, just a couple of years behind, and also the island of Comoro. And so they're examples of partnership. And looking ahead, I think it's similar to what Sophie was saying, that there's more children to help. We would like to try and help whoever we can in whatever situation, always adapting to the local situation. And we also want to do a lot more in e-learning for health professionals with the establishment of a tiered education program as well.
Thank you very much, Graham. They are extremely interesting programs. I don't know why they are thinking of leaving the programs and doing something else. I don't know what they'll do. If I were the one, I think I would actually ask for continuation because it is such an interesting program. Now let's have Anne, and she'll be telling us about Pen Plus.
Thank you. So thank you, everyone, and thank you for inviting me to be here and to share our experience of the Pen Plus partnership, which I represent and co-chair with my colleague Jean Bookman from Boston. I have to disclose that I am a simple cardiologist. I have been learning a lot this week, and even having these discussions during our breaks has helped me a lot to understand what is going on in the arena. So very briefly, I don't know if I have my slides there. I would like to say that the Pen Plus partnership, it's a global partnership. Started to support the results and the report of a Lancet Commission, and I'm happy to say that I'm talking on behalf of several commissioners, among which Prof here, and also several colleagues that represent Pen Plus here, and I'm fortunate also to have representatives of the funders in this room. So thank you very much, all of you, and you feel free to feed in and say things about the partnership. What is it trying to change? We try to change and to fill a gap in NCD care globally that we felt was missing for achieving universal health coverage. Childhood onset non-communicable diseases, and diseases that affected the poorest billion, continue to affect the poorest billion. And that's why after the report, we progressed, we evolved to a network that we called the Non-Communicable Diseases and Injury Poverty Network, NCDI Poverty for short. This network was launched in Maputo, Mozambique, and Boston simultaneously to continue, as we did during the Lancet Commission, to have representativeness and to be able to fill the needs that we had in our sort of framework or theory of change. And that theory of change has 4 stages, the first stage being discussions within the country to prioritize non-communicable diseases, because as we know, these non-communicable diseases of the poverty are several, related to poverty, associated to poverty, causing poverty themselves. Secondly, after this initial discussion, we would design and co-create internally a delivery model. For this delivery model, after the report and looking at the results of the Lancet Commission report, we prioritized conditions that were complex and severe, and conditions that by addressing them, we would be supporting the health system in strengthening itself. So this delivery model service design, then we moved to implementation, and we designed a process where we would have initial countries starting this implementation. And finally, one fourth aspect is the national scale-up. This PEN Plus partnership, put this way, is one of the 4 strategic initiatives of the NCDI Poverty Network. One very good aspect, can I have the slides, Bent, because the images would talk more than my poor English here. So one critical aspect that we wanted was to change the paradigm of training in low-middle income countries for infectious diseases, which is many times easily done by having small courses, short courses, to a paradigm of diseases that we know have been neglected, even in our own courses. My own training, several people here, we were not taught a lot about sickle cell disease, about rheumatic heart disease, because the textbooks usually don't have large chapters on that. So we wanted to invest on training health professionals. And considering the extreme lack of specialists, to decentralize care to rural settings, to bring this care closer to the communities, but do that through task shifting from specialists to non-specialists, doctors, and also to clinical officers and other players in the system, community health workers included. At the same time, give ownership to the governments from the beginning of the implementation so that the government could take their own responsibilities. The slide that I had here showed how within the areas that were identified as, yes, I think it's slide number 6 now. Within, yes, thank you. Within the areas that were identified by the Commission on the Lancet report, Sub-Saharan Africa and Southeast Asia were the areas where most of the poorest billion lived, and for that reason, those areas were also the areas that were prioritized. As you can see by the column mapping there, light green was the area or the countries that initiated this implementation after 2021 when we created the commission, the NCDI Poverty. So we are now expanding from 10 to 22 countries in these 4 regions that you see there. This expansion has been done with the support of funders in cycles of 3 years, and we just entered our 2nd cycle. I will briefly show you the results of the 1st cycle, which, like I was saying, concentrated on training, health professionals. Thank you. Want me to go together? Thank you. Thank you. Yes. Training healthcare providers in models that are more or less standardized but can be tailored to each country, to each health system, and to the level of health providers that exist in such a system. This model also comprehends a certain work with the community that is stereotyped, more or less, brings in the voices of patients, and also has a component of research. So these 4 pillars are essential to what we call PEN Plus clinics. So they are clinics that are more than clinics, as we usually say. Sorry, I went back. So this, I don't expect you to read, but it's just for you to see how this Lancet that had the support mainly from Hemsley Charitable Trust ended up bringing together all these types of partners. We now have streamlines with our main pillars together, and for this second cycle, we want really to invest on monitoring and evaluation, standardize and understand more which models of training can help us deal with these chronic conditions in the setting of lack of specialists, and also advocacy and a sort of reinforcement of the health systems towards management of non-communicable diseases in general. This is to thank all the clinics that have been involved. These are clinics that are born inside public health hospitals, and then they varied in shape and form. These are the results of our 10 initial sites, just for you in a nutshell to see how we ended up having clinics that are more than our 3 sentinel diseases, as I said, childhood onset cardiac conditions, type 1 diabetes, and sickle cell disease, and we end up having a lot more conditions because these clinics are a need in many sites. However, we continue to prioritize these conditions, and that's why I want to show you that our major condition is, here I try to show in the 5, the amount of retention, survival, and you can see for the different conditions, and we have very good results with diabetes. A lot was discussed here. In the model, we provide not just insulin, but also all the kits that we need for self-management to improve education, home visits, etc., etc. But we have several challenges that I think we will have time to discuss. This morning, the discussion on low-middle income countries highlighted the problems that we are having with our model, and I would not want to repeat here. I would like to end by highlighting how important it was to be endorsed on our program by WHO, by UNICEF, and to have several partners keeping their compromise after the Lancet Commission to have these results that I'm showing here to you. And finally, say that all this is with our patients at the center of our program. They are the most important thing for us in our program, and all we have been doing, trying to bring equity and trying to go to where they live, is really to have new ways of looking at results, not only the results that we consider good results for the statistics, but the good results for our people. So I'm very thankful for all the experiences that I've been learning here that came from all the previous speakers and colleagues that are contributing. Thank you very much.
Okay, thanks very much. We're just discussing a few things on how to run again. As you've seen, the initiative may be coming from outside, but we need strong leadership within the country. If there is no leadership within the country, these programs cannot manage. PEN Plus is moving ahead, and you may find it with Life for a Child in the same country and CDIC in the same country. So it needs strong leadership within that country to make sure that they harness everything that will be there. I have two questions which were asked, then I'll ask my colleague to continue, and they will run together. What would be, you'll go through them one by one and quickly, because we think they're important. What are the barriers do you meet when you are implementing these programs? And if you can put them together, how will you go ahead to harmonize approaches so that there is consistency, particularly when there is another partner? Have I made the question clear, or that's a bit difficult? We can, in other words, what are the barriers do you meet in implementing these programs within the country? Okay, and how do you go ahead? What approaches do you really have in mind to make sure that we harmonize? Like in Uganda, we have all the three running. What approaches do you have to make sure that they harmonize and everyone is going to be taken aboard and no one left behind, or someone takes the better of the other part and leaves one behind? We shall go one by one. Thank you very much.
I'll have a go at it first. I think for Life for a Child to be effective in a country, it is determined on the local partner. We need someone who is passionate and dedicated to caring for young people with diabetes. There's many passionate and dedicated people in the health service in the country, but they need to be passionate about type 1 diabetes, and we have that in the countries where we help. And they also need to have some organisational skills as well, because they can't just be a wonderful doctor, they have to be an organised wonderful doctor. And then there's many other barriers that can happen, customs and government and agreements that have to go through the government and getting supplies into the country. But I think and again, our capacity as well to help. But then when it comes to collaboration, certainly with CDIC, I think that again depends on the local partner telling us what they would like us to help with, and we can say if we can or not. And I think there needs to be a mutual respect and not stepping on each other's toes. And there's a long history of interactions between CDIC and Life for a Child, and there was a couple of bumpy periods in the past, but I don't think it's bumpy at the moment. We got on very well, and we respect each other's work. I think we do similar things, but then there's things that we do that CDIC doesn't do, and vice versa. And then the approach to Pen Plus is different again, and so that complements again. And I had a conversation just a couple of days before I left with one of the Pen Plus clinical areas in the country, where we hopefully will be able to help with supplies very soon, because we already help in that country in a different area. So I think it's mutual respect and trying to make things work. And we do need the local leaders in countries. And I could look around the room and look at, I could mention a bunch of people in this country, but Dr. Bahendeka here is a great example of. He tells us what to do and how we can help, and we do what we can.
Yeah, thank you very much. Good question. I think could not agree more. I think it's, first of all, what we try to do. Everything can always be improved. I think the idea is not to have programs running in these countries. I think the idea is really for this to be integrated into universal healthcare coverage, and that is the objective that everyone has. So I think that there is complete alignment with what is it actually that the objective is, and there's a joint objective in that sense that all the children should have the best quality care, both today and in the future, in a sense. I think what we, within country, what we try to do is to really complement if we are in the same country, what can we potentially provide and what are the needs? There's a lot of work being done, led at the global sort of data analysis, research level, and we're also supporting that with Harvard University, but in a different way, I think, to build a cohort. But what we can, for example, do is really strengthen everything in the middle, more the meta system, and have potentially an easier way currently. I would say some of the barriers that we're seeing is, to Graham's point, if you have countries without the strong local leadership that you all have that are sitting here today, because in many of the neighboring countries, actually you don't. If you don't find that local leadership with a structure, as you also say, there needs to be a structure, we're finding it increasingly difficult, even in some of the countries where you see now much more conflict, many more issues of bringing in and being able to fund structures. Is not that easy today to keep a solid NGO structure. There are changes all the time. These are some of the barriers that we are seeing, that maybe last year we were able to work effectively and efficiently in a country, and then conflict is happening all the time. So we're actually seeing a lot of changes that unfortunately is not improving the way we're seeing. So I think that is one of the key things. How do we jointly really help equity in the situations where we are seeing in a country like Sudan, where a lot of the fantastic clinicians that have been leading great job locally that are no longer there? What do we do? So these are the kind of situations where we're seeing, unfortunately, is the changes. Yeah.
Thank you. For PEN Plus implementation, we also face several barriers. The idea is to implement a model that can be replicable and that can be integrated within the health system from the beginning. This requires strong political will. And this is something that we try at the beginning, and for this case, without that will, usually the program doesn't go to these countries. Then it's coordination, because the ministries of health in these countries have several partners. We have partners outside the Ministry of Health also working, and the idea is to coordinate efforts, because funding is never enough. We do not consider type 1 diabetes, and I showed you on purpose the results with other conditions that we are obliged to take care of, because the patients have those other conditions. And then there is also this dilemma about the silos versus integrated way of running the programs, which is initially was a problem. For most countries, and I'm talking about the African countries, we had to incorporate the program within the non-communicable diseases priorities for WHO, because we ended up having a program for children, but we did not have for adults. And because the health facilities are the same, we are sharing the same structure, etc., you need to find ways to coordinate these efforts, and it's a challenge. I think that the ministries of health are a big support also in identifying partners that can be brought to the coalitions that we might be created, and increase and strengthen these conditions. And finally, I also think that there is some power for sustainability in starting this way, which is more difficult, but may end up paying more. Because by being already within the system, we start to ask the government slowly things that you would usually leave for the donors, to slowly take care of the personnel. We have agreements for the personnel to be trained by the funding that we have, but then be absorbed by the Ministry of Health, because it's a new program and does not exist. So I think that all these barriers can be overcome, but it takes a lot of time. And the last barrier we find is the training, which is a very long process in this case. For non-communicable diseases is very different from algorithms for malaria, or for HIV, or for TB. And because we want to do patient-centered care, this is really one area where we have been struggling a little bit. Thank you.
Thank you very much. I also thought was very interesting what you mentioned about, Sophie, about transitioning initially the models, especially between Life for a Child and the CDIC program. There were some overlapping countries, and now you're coordinating to avoid that amongst each other. And so increasingly moving forward, seeing that collaboration, that coordination is fantastic. I'm curious, as you know, as Dr. Bahendeka was saying, you know, now when is it time to go? And thinking ahead towards a transition plan, you know, transitioning ownership of a program, or if children graduate from a program into the local system, what are most effective ways of doing that well that you've seen, experienced, or that come to mind that are needed to be in place to do that well in the future? And then after this, we'll hand it over to Q&A. Whoever.
This is the $64,000 question, isn't it? How do you get there in the end? I think we've had some success in a couple of countries where in one country, Azerbaijan, the doctor said to the government, well, here's this charity from Australia helping, what are you doing? And they did something, and we don't have to help in Azerbaijan anymore. And I think in Uzbekistan, there was wonderful local leadership by Saad Ismailov, who's sadly passed away now, and his cohort. And they started with a terrible situation. And then Insulin for Life started helping. We started helping. They put steady pressure on the government, and I think the economy improved steadily as well. And in time, the government took over all provision of supplies and everything. So we still help with a little bit of advice here and there, but that's all that we have to do. I think with some other countries, it's more difficult, and some countries can go backwards. One country represented in the room that didn't have a tax on test strips, and now there is a tax on test strips of 18%. So it just pushed up the price of test strips, and so it's a matter of putting together data. You can't advocate to a government if you don't know how many young people there are, and also put the costs together, and then it's supporting the advocacy of the local partners, and I think also showing what can be done and what other countries are doing. For instance, Rwanda is doing more than some other countries, and so making that visible to other countries in the area. And we'll be developing a repository of this information, which will give lots of information on what's available and what's happening in the country, and then hopefully countries can push based on that, saying, well, what about us? What are we doing? But it is a very difficult question, and I think, frankly, things have gone backwards over the last 5 years with COVID, and then the inflation that happened post-COVID, which is still happening, and the turmoil in Northern Africa and some other places. Sadly, I think we've gone backwards in provision over the last 5 years.
Thank you. I don't know if anyone else wants to share their perspective or.
Yeah, I can try. Very aligned with Graham. I think what is the transition criteria? When are we we tried to do an exercise together with input from many of the doctors and leaders in the countries, and I would say theoretically, well, so to start on the positive note, there is actually progress due to a lot of the local leadership in states in India, in if you look at policy-wise, and I think some of the policy analysis that's being done globally, yes, there's definitely a lot of push being made. We're seeing new actors coming on board. I think type 1 diabetes is on the agenda within the NCDs. So there's a lot of actually positive work being led by the Lancet Commission and the different global actors that are, where type 1 diabetes is part of an NCD youth and child maternal process. A lot more capacity building has been led. Policies are changing in some of the countries. Now, from that to actually having stable long-term budget lines within a ministry where you're purchasing what's needed, that's not happening in all the countries. It is happening in some, frankly, very few, and we're seeing real progress and real, I think, interest and understanding from the ministries of health in many more countries because of what's happening. Now, to Graham's point also, then you can theoretically do an exercise and you could say, we have a country like Bangladesh where last year the country started providing, for example, for all the children, and now sort of due to instability, it's not necessarily possible. So there's also the geopolitics, which just is, if you just look at the Ministry of Health and you look at national budgets, it's also not happening in a lot of the countries. So I think beyond that, I think we've been looking at, well, what are really then the progress that's being made in terms of guidelines? A lot of countries are starting to apply some of the different guidelines, doing national guidelines in terms of improving the quality of care. So that's already a step. I think even though you don't see the ministries doing things, a lot are just taking local leadership and doing other things. Data and quantification, even in countries where there is reimbursement of insulin and coverage of strips, maybe the countries, because of the fragmented healthcare systems and hospitals having their historic budgets, maybe it's not that easy to know where are the kids, how much do we send out there, how much do we send out there. So there we're actually also happily supporting together with other partners in terms of trying to then simply plan, project, and quantify better, because that's, even if there is political will, you need to know where to send the strips and why. So I think actually a lot of things are happening, even if there's not reimbursement, there might be something else. So I think there's a lot of these elements that we try to put in place before we exit a country.
Thank you.
Yeah, thank you. I think that also the fact, I don't know, like you said, how to define transition and when to know that is the good time for transition. We work with budgets and funders that have limited time, and we usually guide our work looking at that. But I think that, yes, in policy, there has been a lot of improvement. And I think that having these programs in country, originating data, originating research, helps a lot, because the first problem that we had, and this was really the engine for the Lancet Commission, was if you don't have data, you don't have the patients. You don't have a dialogue to start with anyone at the Ministry of Health, because there are millions of children with malaria, millions of people with tuberculosis, millions of people with HIV, no children with type 1 diabetes. So the first point and the first strength that I think will last forever is that we are starting to have data. So we can start this dialogue at the ministry level, at the policy level. Second is that once we start, we should also make it possible to have surveillance systems, health information systems that stay in country. Even if they are related to small NGOs linked to one district, to one province, they should stay there, because this is a way to continue pushing for quality in information, quality information for political decision. And finally, I think that we need to involve the community in the sense that these non-communicable diseases programs are really changing the arena in low-middle income countries. We have been used to one disease program-led programs that have very high rates of cure, because you treat, you don't have plasmodium or blood, you cure it, success. It's completely different with non-communicable diseases. So we need to reorganize our way of thinking our health systems in low-middle income countries. What is the role of the other sectors? Why do the patient need to pay so much for transport if type 1 diabetes is chronic, is forever? Do we have a policy in the transport? No. So if I'm sick, I'm equal to someone who's not sick. This is the type of systems that we have. So we need to rethink the whole systems, the whole policy, multi-sectorally, to then benefit the work that we are all starting in these countries. That's my opinion. Thank you.
Thank you. Clearly very complicated, but thank you. So now we have at max 10 minutes. So we'll take some questions from the audience. 15? Okay, 15 minutes. So we'll do, I'll take 4 questions to start, and then we'll go from there. I'll start with you, Dr. Bahendeka. Oh, does someone have a microphone? Yeah.
Thank you very much. I think we're living from here with a good knowledge of what your organizations do. But I want just to come back to type 1 diabetes, not like the PEN Plus with other things. I'm so happy that we can help children and they don't die immediately. What in your programs have you integrated looking for outcomes in these children you are following, so that we know the level of A1C, we know the sort of complications they're developing, so that we don't save them from dying early, but we strain the healthcare system by leaving them have a kidney disease, heart disease, and the rest. And my last comment is that we should ensure that we hold governments responsible to take care of the health of their citizens. I think this gift of saying that we are poor and then we just give and they use it and they forget their responsibility is wrong. We have to, and those of us working in countries, make sure that they take the responsibility. They have money, they're not poor. They organize National Day celebrations and open maybe 1,000 bottles of champagne. This can buy and take care of people with diabetes, and we have to sensitize them to put in their budget, not that we give every time and they don't do anything. Thank you.
Okay. We'll just take 4 questions. Dr. Zabin, over here. Yeah.
Thank you. Dr. Bidora Zabin from Bangladesh. I must give my thanks to CDIC and LFSC program, especially in this platform, because since 2010, we, with the Diabetic Association of Bangladesh, we have the collaboration. And I should say that this is a unique center where we are working with the 2 programs complementing each other under one umbrella. So if you look into the outcome of like more than a decade, that is 14 years, you see, we started with 400 patients supporting from this program. Now more than 8,500 patients in a single center in Burdham Hospital in Bangladesh. So not only the number, what was our objective from CDIC and LFAC perspective, that this patient should have good glycemic control, they should have a good quality of life, they should continue their life, and also there shouldn't be any complication. Just to add with the previous question, recently, our aim was always, because when we started, our A1C was like, yesterday I remember from Ghana, she was telling that 11.8. Same we had in 2010, almost 11%. Now our mean HbA1c is below 9, which was our dream, that is 8.5%. And if we look into the complications, recently we had, in 1,200 patients, we could see that only 2% patients had retinopathy, which was very mild NPDR, which we say only 2 patients had severe retinopathy. And early nephropathy was found in 22%, and 1% had only the CKD. So that is proteinuria or macroalbuminuria. So you see, these 2 programs is doing such a great work helping the Diabetic Association Bangladesh. That's true, but the main question is always there. I always ask Graham and Sophie that up to 26 years of age, they are having unique comprehensive care in this center. But after that, is real. They get the insulin from Diabetic Association. Yes, we can afford from the Social Welfare Department, but they're not having that comprehensive care. That's the real question. And another question is always there, the sustainability of this unique program, which has saved such thousands of patients' lives and them make them a good quality of life. Thank you.
Thank you, Dr. Zween. 2 more questions. Back right.
Yeah, thank you so much, Deladka Kunze from Africa CDC. I'm really happy that here we are talking about transition to sustainable program. Because before we come here goods, numbers, goods in terms of impacts. But now I'm happy that this conversation is about sustainability and sustainable program. And I like what Dr. Anna mentioned about strengthening the surveillance, the national surveillance system. I visited, I think, 1 or 2 Pen Plus clinic in Zambia and was it in Benin. One thing that struck me is they are still using their own system to collect data. And sometimes it's not plugged into the National Health Information System, the DHS2 most African countries using. And you mentioned something very important. Even if we are doing it in 1 or 2 districts, how do we ensure that this is informing the core indicators that we need to collect at the national level? How do we also use system data interoperable? This is very important. As you said, without data, we may not be able to convince the government to invest more. The same thing apply to workforce. In most of the country that we are going, some people approached us, community health workers, nurses. I've been trained under this program. When they pulled out, the ministry, they completely forgot us. And they're, oh, you are coming to fill the gap. That demonstrates that sometimes we train and we don't report to Ministry of Health, at least for them to have a database of those who are trained and be able to use it when it's needed. So how do you navigate all those? You gave some responses, but how do we move faster? Because clearly we need to move faster with this. Thank you.
One last one, and then that's it. Go ahead, Richard.
Okay, thank you so much for all the programs that have been presented already. Yes, I know most of it, and I think most of my friends also have been saved by some of the programs that are being shared here. So I have a question for Sophie. Yes, with everything you have heard in these panels, all the discussion that we have had so far, especially with the challenges in countries that you are serving with your organization, we wanted to ask, is it true that the CDIC is going to cease in 2030? And if it is, have you considered ways in which maybe the government or maybe try to capacitate them in a way that they are going to continue, especially for the people that have been saved with your programs? I have so many friends, they've been complimenting the work that you do. So we want to know, like, why is this the case? And what have you done so far? Especially maybe if you have not been awoken by what people have been sharing, especially with the challenges, maybe you could go back and say, I think we need to reconsider. So is it true that your organization is going to cease? Okay.
Thank you. Very fast.
Okay, I promise.
1 second.
No, I'm just curious. So it's wonderful to hear from you that that both programs has plans to expand, which is amazing and huge expansions, if I heard well. And we have been hearing here about a lot of need. So my question is, so how can the different countries, different organizations here, present here, or watching us approach you to help you to expand, I hope.
Okay. Okay, so I'm gonna, 2 of the questions, there were some that had some similar themes. So one of which was to Anna Sophie specifically about the CDIC programs closing and transitioning. And I think one of the things I heard very loud and clear here was the lives that have been saved through these programs over the years, which is tremendous. And how do we continue that momentum as programs transition? So, Sophie, that question to you, and in connection with that, Bedora's question about after 26 years of age, then what happens in sustainability of care transitions? The question around monitoring and complications and ensuring quality of care in terms of A1C and all those data points. Maybe, I don't know, Graham, could you take that, what Life for a Child is doing in that regard? And then for Anna, the question from Africa CDIC about national surveillance systems and data sharing, and ensuring that the ministries of health have access to critical information like who's been trained, et cetera. So maybe we'll do it in that order. And then we have only 5 minutes, so if you can keep it relatively brief.
Nice. Okay. Well, thank you so much. I'll take 1 minute. Now, let me try and address some of the questions. I think to the question on HbA1c, Prof. Mbanya, there was, and related to the outcomes, what have we done? We've actually tried, and there's been a lot of discussions, really good discussions on the access, the pricing, and the affordability. Obviously, I'm representing Novo Nordisk and not but we have been working, we have I think, fantastic partnership with Roche, but we've also been working to negotiate better prices and better access to diagnostics machines. So we have lately put in place in the majority of the clinics HbA1c machines and have negotiated prices for reagents for HbA1c, as the CDIC partners know, so that the kids can control better. And what we've done also is to make sure that the negotiated prices are available for all the partners and the countries. So to try and really commence that process with different partners, so that to make it as affordable and sustainable as possible. Regarding the data systems and the data, and I think it's fantastic, so much work is being done at the national level to quantify, project, plan, because otherwise, how can you purchase any insulin or any supplies, and how can you do anything? We don't do anything. We don't do anything without it being integrated into DHSI2. The offerings that we have developed with Dura Technologies are available on a website called t1dreg.com. Every country in the world can go in and look. It's with the variables that anyone can adapt and take in their own setting and own that data and have their own system. It's integrated into the DHSI2, interoperable. So I don't know if that question was also about that, but happy to provide more information. I think the sustainability part is always the difficult one. Yes, there is a commitment until 2030, currently under the Changing Diabetes in Children. And that is what we know, that we have funding and possibilities support until. I think that's there's a target for everyone, even with the SDGs, and the 2030 is sort of the cutoff date. I actually have to be very honest and say that we don't know. There's a lot of hope, and within the next 5 years to really move towards sustainability and really see transition in a lot of the different countries, which I hope is the case. And that is the current sort of funding and commitment that we have for the target under the Changing Diabetes in Children program. Maybe the last part in terms of sustainability, we do really encourage and make sure and clearly have a mandate for the partners not to just train and just do a training where the children cannot, or the HCPs cannot get a job. What we really hope in terms of that is that even the Type 1 alumni can become educators. We are supporting that in many countries. We are really encouraging, and this is happening by itself, by the way, that the certification level is done at the national level so that it's a sustainable integration into the healthcare system if you receive a training. I hope I addressed the majority of it, and I think my time is up.
Before you leave, because Jean-Claude's question about quality, I know it was directed PEN+, but it also applies to the whole group. If I can extend it, because when we've been here, one of the things that transpired is that incorporating people who live with type 1 diabetes improves the program. Is it time now, despite that there's remaining a few years, to reshape our design of the clinics or a design of the way we conduct the programs to include people living with diabetes and the community itself so that it improves. That, of course, has implications that it will have some money added. I know it's a hard question. It hasn't got to be answered now.
I think that's a great idea. I think there's some centres that do that already. The Aurangabad Centre here, represented here from India, and some other centres. But we can do it. We can do more of that, and deliberately trying to encourage and foster that as a program, sort of not directive, but suggestion is a good idea. So I think we can take that one home. I think, Jean-Claude, on your question. And we feel it too, and you're in the hot seat because you're seeing these young people who are in 25 or 27 and developing renal disease, and then they can't afford a transplant. It happens, and it will continue to happen. It happened to the people when they started receiving insulin. It happened in Australia. It still happens in Australia. But with time, it won't happen. And there'll be cohorts here, and we have to work through those cohorts and have a vision. And I think I was going to, even before Dr. Sabine stood up, I thought I'll use that centre as an example, because they're now achieving A1Cs in the 8s. And yes, the target is less than 6.5, but that's a sort of magical dream in some ways. If you can get an A1C in the 8s, your chances of end-stage renal disease or blindness over 30 years are almost zero. And it isn't perfect, but it's a huge achievement. And even bringing it down from 11.5 to 9.8 is a huge difference. So there will be cohorts going through. The first cohort, those who are unfortunately more prone to complications, it will be tragic for them and terribly upsetting even for us as physicians. But it will get better. And I think on the phasing out at certain ages, this is something that's troubled us ever since we started, of course, with the first children graduating from the program as young adults. But some of those have careers now. Some of those have their other options for support. Some of them are doctors now. It's quite common for them to be doctors or nurses. Some of them can get help from Insulin for Life. And sometimes the limited insulin that is available in the country, for instance in Bangladesh, can be directed more towards the older ones, and our insulin goes towards the younger ones. We don't have all the answers there, but there are some partial answers. And in some places there's vocational training programs or helping people through college and all sorts of things like that.
Thank you.
Yeah, thank you. We already work with the Voices program involving the patients, and the patients also are involved in these discussions about sustainability, about transition, and I think that maybe we are all dreamers. If we were not, we would not be here. But the point is that if we treat these kids early, then our major outcome is for them to have what we call a normal life. And if they have a normal life, they will be inserted in their own community correctly, and we will be able to give to the society and to do their own life. And I think that this also contributes to create social movements that can push, because the governments in our countries will not be able to do everything because they don't have much. But I think that we also help supporting social movements that can move all our desires forward, and support communities, support researchers, support NGOs in really implementing systems that can provide and can support these sustainability post projects. I think that was for me, and the one on surveillance was already said. And back to Professor Jean-Claude, I think that although you said I'm not talking about the PEN Plus, I want you to talk about PEN Plus, because integration in these rural poor communities is extremely important. We don't know how to do it. It doesn't mean that we should not do it. These children do not only have diabetes. They have diabetes, they have poverty, they have other conditions, they are not going to school, they have malnutrition. So we need to see them as a set of problems that pushes us to work together more and more. Thank you.
Thank you. Bent gave us till 5 after, so we're going to wrap up. I'll hand it to Silver to just say a closing word, and then we'll hand it over to the second panel.
Thank you very much, Sylvia. We must thank our panelists who have, I'm sure, given you ideas about how international corruption. Sorry? Oh, okay. Until so that the international collaboration has been going on very well. Jean-Claude is eager to get to the to the panel. So in the just in 1 or 2 minutes, let me summarize what has transpired. That mainly these programs, international collaboration, will work as long as the government, the people, the community have strong leadership within themselves. They'll give you, and what they give you should be put to use. And when it's done, then both of them will move ahead. The barriers seem to be mainly at the national level, and hardly did we see any crash within themselves contributing towards the improvement of diabetes care in type 1 at the national level. With that, thank you very much.